to our outpatient department who was quite young. He was 40 years old, and he didn't really have a medical history. He was very fit. He was doing a lot of exercise and looked very fit. And the only problem was that he started to notice that he was retaining fluids in the last months and weeks or so, and he was having edema. And when he came in, he had he had gained something like 15 kilos or so, and his legs were very, very swollen. And he was developing shortness of breath and had a very high heart rate with an ECG, which was kind of awkward because we couldn't see any P waves, and the QRS complex was very, very wide. And his blood pressure was very low, so he was almost in shock. So this is the echo I'm going to show you of this patient. And again, like always, I want you to follow along and maybe ask some questions. And this is the first echo I'm going to show you. Okay. Parasternal long axis view, as you are probably all aware. First thing that you notice is that, yeah, you have a pericardial effusion here. Remember, there's some fluid here within the pericardial sac. And then the left ventricular function doesn't look that normal either. Okay, so this is the first image I'm going to show you. And I'm not going to say too much about this image here because I would want you to see for yourself what there is to see. But again, the pericardial effusion is here. Look at left ventricular function. Look at all the other structures that you can see. Okay, just a closer view of this image. Now let me show you this image here. Look at left ventricular function. This is a 4-chamber view. Now this was pretty difficult to investigate the patient because he was really in a bad shape and he couldn't lie down on his back. And we were kind of thinking if we shouldn't bring him to intensive care at this point. And we, as a matter of fact, we did. Right shortly after this investigation. So the images are maybe not as good as you would like to have them, but still I think the information is there. Look at the left ventricle, look at the right ventricle, at the atrius, and at the pericardium. Now this is his tricuspid valve, color Doppler flow. Look at the regional wall. Look at this here. Okay, anything particular that you see that could make you help the diagnosis? Remember, he does not have any chest pain. He does not have any ST elevations. He's quite rapid with his heart rate, as you can see, and you see that the QRS complexes are very, very broad and unique. Now, this ECG was obviously just not ideal. Okay, I just see that Yvonne posted a question saying that she thinks that the patient has right ventricular volume and pressure overload. This is a very good thought that you have. Yvonne, I just want you to hang on for a few seconds because I'm going to ask a question which is certainly going to answer your question too. Okay, so this is a 4-chamber view where I'm focusing here more on the lateral region. And this is an image from the back, as a matter of fact. And here is the inferior vena cava. And here's just a still image of this. Okay, I think I've shown you enough of this patient. Now I would like to come to the first question I have. Can you put up the first question? Okay, are you all seeing the question? Good. Okay, so the question is, what does this patient have? Does he have acute pulmonary embolism, myocarditis, Takotsubo syndrome? I've shown you a case of a Takotsubo before in one of the webinars, as you might remember. Myocardial infarct, okay. Tachycardia-induced cardiomyopathy. Okay. Have all of you signed in? Okay, I think most of you are actually putting, well, I'm not going to say it because the poll is not closed yet. I think you can show the poll. Most of you have voted. Okay, so the result is that most of you think it's acute pulmonary embolism. followed by myocarditis, and then a few think it's tachycardia-induced cardiomyopathy. Well, to tell you the truth, at this point, all of these diagnoses were actually in the back of our head. And most of you picked up the problem that this patient has is the right ventricle is completely abnormal. Take a look at the right ventricle here. It's dilated. You have flattening of the interventricular septum, especially here during diastole, actually, but the left ventricle also has a problem. So he does not have completely normal left ventricular function. Now, I'll give you the diagnosis in a second, but I want to show you a few things which are very, very striking. And I'm going to show this to you because it's such an eye-opener when it comes to right ventricular function. The interesting thing here is that this patient literally does not have a living right ventricle. The right ventricle is practically dead. What you can see here is you can see that the patient has no wall motion here of the right ventricle, and I'll show you a later study too that documents this as well. But look at the tricuspid valve. You see the tricuspid valve, how it moves? And I'll give you another image which documents this even nicer. Here, this is the right ventricle, and the tricuspid valve is just moving like a sail in the wind, and it's only opening because blood is flowing through the right ventricle, which is triggered by respiration. We could actually document that the tricuspid valve was opening with relationship to the inspiratory phase. And if you look at the Doppler signal now across the pulmonic valve, this is something that you should really keep in the back of your head. First of all, this patient has very low velocity flow across the pulmonic valve. So it's 0.5. Usually you'd be somewhere in the range of maybe 1 meters or maybe even above 1 meters. But the velocity is very low, and you can see that there's even diastolic flow across the pulmonary artery. So this patient has very poor right ventricular function, and he's only processing blood into the pulmonary circulation because basically the left ventricle is driving it, and because of inspiration. So this is also the reason why this patient does not have, at least in color, such severe form of tricuspid regurgitation. The valve does not close, that's true, but there is no contraction of the right ventricle to push the blood back. It's just flowing back and forth. You can even see spontaneous contrast here. This is a very nice view showing that we now put down the velocity range here to show you the slow flow that you can see here across the tricuspid valve. So basically what this patient has, he has very severe form of right ventricular dysfunction, also seen by pleural effusion and pericardial effusion and a very wide inferior vena cava. So all this fits to severe reduction of right ventricular function. Okay, so let me go back now to the slides and let me show you what this patient actually had. And it took us some time to figure out because we were close to acute heart transplant in this patient. We had all these tests lined up. We did EPS, we did MR, we did all sorts of stuff. We tried to exclude right ventricular dysplasia. Eventually, the only thing we really found was that the patient had very extreme high antibodies of anti-Rho, which is an immunologic marker, which you will also find in Sjogren syndrome and SLE. And our theory behind it was that the patient had some form of autoimmune disease causing inflammatory cardiomyopathy. And since these values were extremely high, the only thing that we could offer the patient was plasmapheresis. So we put the patient to plasmapheresis, and he's still in the program now, and he improved actually with this therapy, and he gets plasmapheresis now I think once or twice a month to lower his values, but he's shifting back the values, so he's not completely normal. But let me just go back and show you the images of the same patient now at a later point in time. This is now 2011. Here you can see the images. The patient has improved with respect to his left ventricular function. The patient now has defibrillator in place because he had tachycardia frequently, and he even had several shocks applied to him with the defibrillator in place. You see that the right ventricular function has improved somewhat. You see that the tricuspid valve is now closing, and you can see that he even has at least moderate contraction now of the right ventricular wall. At the beginning, I didn't show you this. The velocity here on the free right ventricle was maybe 0.3 or so. Now he has 1 centimeters per second. So he did improve with his right ventricular function, and he also improved clinically, but certainly he is far away from being normal, and we can just hope that he can stay the way he is as long as possible. If not, then I'm afraid he will get a transplant, I guess. He's a transplant candidate.